So welcome to NUR 203 HESI Q&A. I do this every term as much as I can. I try to go back and look at all the HESIs, look at the concepts that were there, and making sure that you can figure these concepts out from the information that you've gotten all term long. So I think this is the first thing everybody's heard me say. Nutrition, nutrition, nutrition. But nutrition encompasses so many different things. So let's look at nutrition and how we can use it to help us get better, or how we use nutrition to keep us from feeling bad. For instance, irritable bowel syndrome, IBS. When you have children that have IBS, that means the nutrition goes into the intestines and the stomach, and it's so irritable, there's no chance for it to be absorbed. So nutrition is lost through diarrhea. Okay. What happens when you don't have enough nutrition? You're going to see it, right? Because you'll see it with developmental delays. They're not going to be in that height and weight bracket because we do that every visit, right? And we're going to be looking at those developmental delays. Are they able to hop on one foot? Are they able to say how many words in a sentences? All of these things will be giving us the clue that maybe this child needs a little bit better nutrition. Another way we lose nutrition is reflux, gastroesophageal reflux disease. I think in infants, nutrition is the most important because that first year of life, they grow so much, don't they? So if you have an infant with reflux, you want to keep that milk, whether it's formula or breast milk. We want to keep it in the tummy. So we add a little bit of rice cereal to it. What that does, it makes it thicker. And even though rice cereal is not, quote, ready to be tolerated yet, the child's not 6 months yet, but what it does, it keeps the milk down. So they're gaining nutrition, even by adding something they may not be able to use in their body, and it may come out in their stool. Another thing is, let's say you have a child who's fighting an infection, like a bone infection called osteomyelitis. What are type of foods? Wound healing is another thing. And you want to increase your proteins, right? So fruits, vegetables, whole grain breads, low fat dairy, beans is a great protein, lean meats, and fish also. So think about not only food that we eat normally for nutrition, but what food can we add if we have a condition that can help us feel better, right? As in that wound healing could be protein, or that bone that needs to be, has an infection. How can we help the body help itself? Nutrition. And then talking about underweight, overweight child, always remember that you should get some sort of food diary, whether what did you eat for breakfast, what did you eat yesterday, or if it's even more involved, get a 3 day or a week old. Tell me what you're eating all the time. And then we can look at it and say, well, this is why you're gaining weight, or this is why you're not gaining enough weight. With obesity, one of the questions we can ask, so are you in school, regular school, and do you have, physical activity? Do you have PE? Do you go with gym? Do you go out running every day? It's an important thing because if not, then the parent has to do something to get that activity up. So another thing with nutrition, those celiac children. Remember, celiac is that they're allergic to gluten. Your responsibility is to look at the lunch tray, the breakfast tray, the dinner tray, or any snack you bring in that room to make sure they don't have gluten. Many times they'll put you on, a very light diet, and they'll put things like crackers on the tray. And a gluten-free or a celiac diet, you wouldn't want those crackers because that's the type of flour that these children can't have, that wheat, the rye, or that barley. Okay. Another thing that can inhibit children from eating is thrush, right? Those white patches on that tongue. And you can't remove it. It's there, it's stuck. Remember, this child, it's a yeast infection. It requires medication, and you're going to swab on some nystatin on there until that white patches disappear. And you're going to teach the parents, make sure that you wash those nipples and those bottles well, so you get rid of the yeast in between each feed. Another thing, diaper rash. You don't, well, diaper rash many times can be related to the food you eat. I know that certain foods could cause diaper rash in all of my children. So I'm very aware of it. But remember, children with diaper rash are not happy, especially at night. And then you're not happy because now they're waking you up because every time they urinate or stool, it burns. So they're going to keep them up all night long, and you too. Okay. Make sure we keep it open, wash it, soap and water, apply some sort of ointment, whatever it is to help it. Everybody likes their own, whether A&D, Desitin, whatever works best. And then, no, we know nutrition is we introduce usually solids at 6 months, one at a time, every 4 to 7 days, making sure there's no allergies in between. Okay, growth and development in your infants. So you have an infant that you're doing your morning assessment when you first come into work, and you're doing that initial assessment, and you're doing the head circumference, and you're noticing that it's increased several centimeters. What else can clue you to something is going wrong? Infants have something that can tell us so much about so many things, and that's that little fontanelle on top. Is it the anterior or posterior? Remember, posterior closes very quick, about 6 to 8 weeks, and sometimes you barely even see it. It's the anterior fontanelle, the one up top. And if we're having hydrocephalus, we're going to see it start getting rounded. It's going to start feeling full. Okay. Newborns that are born, the only way that they comfort themselves and explore the world is through their mouths. There are some conditions that as they're born, they cannot take anything orally. Remember that tracheoesophageal fistula? If they drink, that milk goes directly down their esophagus, across that fistula, and directly into the lungs through the trachea. So this is a child that we must offer a pacifier, a non-nutritive sucking device, because it soothes them, it calms them, it's what they need. It's been found through multiple research on that. So another thing that we're going to hear as nurses is, her sister was, doing this at 8 months, and my son isn't doing that. And what's going on? What's normal for instance, an 8-month-old to do? Well, knowing that 8 months, that big one is sitting alone unsupported. That's always 8 months. Any book, anything, I've never seen anything change with that one. And if this child is 8 months old and sitting up unsupported, they're good. It doesn't mean that the sister was standing up and walking by 9 months that the brother needs to do that. Remember, siblings are different, children are all different. As long as they're moving forward, we're okay. Failure to thrive. What does that mean? Well, we weigh our babies. And we know that we're looking for them to increase weight and increase height every visit they go to see the doctor or the urgent care or the ER. We always measure all those three different areas. And if we're seeing that they're not gaining weight consistently, and I've actually seen 10-month-old children, infants, only weigh in like 8 and 9 pounds. And we call these failure to thrive. There's many different reasons why that happens, and there's a big workup that has to be done to figure out. Sometimes it could be metabolic something, but what do we do to treat that child to get them the nutrition now? Because remember, they're growing so fast, and cognitively they go from can't lifting a head to walking and talking in a year. So we need nutrition. So What we do is, because they don't want to eat a lot, is give high calories to that child. That calories will make up for a little bit of that nutrition they're not getting, and hopefully will give that child some weight because they need nutrition to grow and to be cognitively aware. Cradle cap and infants. I think this bothers us, especially if it's a little girl and we want to put bows and cute little things on their hair and they've got this white crusty things in their scalp. Well, it's a normal thing that can happen. What we do is wash it with soap and water normally and then moisturize it. Olive oil, baby oil, lotion, something. Let's get it nice and moist. And then you take a fine tooth comb, not a spoon, that's funny, and you gently comb it, okay? And it's not going to happen the first time. It might happen, a week or two down the line, but you will get all that cradle cap out of there. Now, toddlers, we've talked a lot about them. These are those children who are, I think, the most difficult to work with in especially hospital setting. Remember, these children must be kept on their routines. Even though they're toddlers, they understand a lot. So let's, get out the play stuff. These children love to play. So get a doll. Let them touch the doll. Let them listen into their breast sounds on the doll. Then listen to on them. Again, get down on their level. Don't ever sit above them and make everything play, play, play. And of course, keep the routine. And if at all, keep parents staying with them. Preschoolers. Now, preschoolers are getting more and more independent. I think the biggest thing is now they're talking at four or more word sentences. They're hopping, skipping, jumping, they're tying, they're um, buttoning their buttons. So, again, this child needs less routine and structure than a toddler, but still needs quite a bit. And again, they're getting more and more independent. Now, I throw one of these slides in on autism. Now, autistic children, I've said it in class, we don't diagnose them till at least they're 2 years old. We're going to see, of course, signs and symptoms of it. But then we have to somehow figure out, are they autistic? Well, many facilities have questionnaires or assessment sheets or checklists to determine what's going on. And one of them is a modified checklist for autism in toddlers. And you just go down the checklist and check. And if they add up a certain amount of points, that yes, you can think that they are. And of course, the doctor has to put them to psychologists, psychiatrists, and get them the treatment that they do need. We know autistic children, no eye contact, sitting alone, repetitive behaviors over and over and over again. I've mentioned all about my little boy who goes into daycare, does what he has to do, goes, sits in the corner, and then takes a little stool and puts a truck on top, and then takes a doll and put on top of the truck, and then take a house and put on top of the doll on the truck. And then he takes the house down and the doll down and the truck down. And he does that over and over. I mean, 10 times, up all of them, down all of them. And it gives them comfort. Okay, so you let them do it. School age children, this is an absolute great time for teaching. It's a lot of great time for teaching them about obesity and eating correct foods. You're going to see a bunch of programs for it. And again, any problem with food, weight management, too much, too little, too heavy, too skinny, that food diary will always be your answer. That's the first thing we have to do. Now, there's another thing with school age children where you see children that are shorter than the other kids. Many times it's the family. The family's all short. So the parent's going to say, is there a way we can get our child taller? Well, sure we can. If the family has that hereditary component that they're tall. But if the whole family is short, you're not going to get much more height out of that child. And that's just to be open and honest with those parents. Remember, if kids are in the hospital, that many of them have brothers and sisters or close family members. Remember, today we're so lucky with FaceTime. Years ago, I would send home things that they colored and draw or made for them just to keep them that, yes, Joey in the hospital is thinking about Timmy at home, and those things are important, okay? Another thing to think about is that hospitalization, that reaction, that separation anxiety, those things. School age children tend to be left alone more because they have that ability to be able to, but it doesn't mean they like it. Okay. School age children, if it's the first visit in a hospital, there's nothing to relate it to. But what if this was a chronic child? What if this was sickle cell child? What was previous hospitalizations, reactions to it, right? We got to remember that. Adolescents. Adolescents are now almost adults. And they are at this point expected to start managing their care with the parents, right? You still need parents to make sure they're doing it, but it's sometimes where we could put children, adolescents, in with other adolescents to be able to talk about what they're going through, whether it's seizures, whether it's diabetes, whether it's congenital heart disease, doesn't matter. Having them on the same unit, talking with other adolescents really helps. It lets out whatever those frustrations are. One of the questions you're going to see on a HESI or on your NCLEX, they're going to ask Tanners, guaranteed, okay? And the way that I've told you all in my class to remember it is, it's 5 stages. One is nothing, that's no maturity at all. And 5 is you're completely done. So you're left with 2, 3, and 4. 2 is breast buds and enlarged scrotum. Okay, so literally, you've got 2 to choose from. How far developed are you to be able to understand what level of tenor stages are there? And that's the only thing I can tell you how to remember that. Another thing adolescents are getting into is that body image, right? And getting into liking somebody else, whoever it is, male, female, whoever. They're starting to get these feelings, and they're going to be starting to experiment. Um, Adolescents will ask for birth control pills, oral contraceptives. Now, do you have to tell the mother? No, you don't. But what you can do is just counsel them on the benefits and risks, oral written information, not what your opinion is. Okay. Yes, you can tell them. No, you don't have to tell the parents unless something they've told you is going to hurt themselves or others. So, Piaget. Piaget is all about how to think. If you can remember Piaget and thinking, putting things together and thinking about stuff, remember object permanence? They saw something and now you hit it and they know it's still there. Older kids, you put their toys in their toy box, they know the next morning it's still there. They're going to go get it. Even infants understand object permanence. Erickson is about how the people around them, how that child responds to people around them. So infants cry because they want to get fed, changed, or they're hungry, right? That's all what's going on with them. And when you meet them, that's the trust. That's when their needs are met and they're happy, happy babies. School age children like to do things well and they like to be praised for them. So, industry versus inferiority. Industry is my product, my factory, my house. It's what I do well, whether it's running fast, whether it's spelling good, or maybe I'm good at math. That's what I do well. I feel a sense of achievement, accomplishment, and everybody praises for me, and it makes me feel good. But I don't do everything well. I might be good at math and the slowest kid running in the whole school. But again, inferiority, and that's my industry, what I do well. As I said, adolescence is all about me. What do I look like? What's my role for the future, right? And we know that we can ask parents to leave the room to get a better, sometimes medical history. So let's go into some of the body systems now. We've sort of touched on growth and development, the way to think in that growth and development area. You don't have to go bonkers in it, okay? Hematology. It's all about the blood, whether it's white cells, red cells, or platelets. So hemophilia is all about some factor in the blood is missing. And when they fall or get cut, they're going to have prolonged bleeding, where it might have taken 10 seconds for something to stop bleeding or a minute. Now it's taking an hour for that bleeding to stop. So doesn't mean that when you're born, you know that you're a hemophiliac or not. It could be a child later on in life. So let's say you've got a toddler now who's hemophiliac. What is your job as a parent? I had one slide that I use for my muscular skeletals, all about rice, right? You rest, ice, contain, and elevate. Fall down, hurt your knee, it's swelling up. That's what you're going to do. But now we add a P in the front, price, protect it. So you don't have to do the rice on the end, okay? Pad the furniture, pad the coffee table, pad the dining room table, whatever's sharp, you don't want them to be hurt. And as I said, any problems falling down, you hurt your knee, you hurt your toe, you hurt your elbow, you're going to do rice. Rest, ice, contain, elevate. Everything to decrease the bleeding. Nosebleed intervention, thumb and forefinger, bridge a nose, lean forward 10 minutes. If that doesn't work, head to the ER. They're either going to have to do surgery or sometimes they actually put nose tampons in there. It's actually pretty neat. You actually see it looks like tampons in there, but it swells up and it's like pressure and it stops the bleeding really well. Platelet count low, whether it's from an ITP or whether it's just leukemia, or maybe it's just a child who's in sepsis and now the platelets are being eaten up and now the platelets are low. Whenever we have low platelets, we're always concerned about bleeding. Doesn't matter the reason, we're worried about the bleeding. So you'll be placed on bleeding precautions. Sickle cell disease. Sickle cell disease is due to cells getting stuck in bifurcations, and then they get stuck, and all the cells back up, and it swells, and it's hurt, and it's painful because they're tiny blood vessels, and those little sickle cells can't get through. How do we treat sickle cell? Priority. Well, we want to dilate the blood vessel. So, bolus fluids, put heat on it, which will also dilate it. And that's going to help that blood go through, decrease that clog of all those blood cells, and decrease the pain. So, we're going to treat it with fluids. We're going to treat the pain at the same time, but priority will always be fluids. Another thing we need to remember these children, we wanted them to be normal. So if they're out playing soccer, baseball, sure, they can do it, but they need to be drinking constantly. They need to hydrate, 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 hydrate. If they go and they live in cold weather, they need to dress warmly to keep it from constricting the blood vessels and causing a sickle attack. If they go in an airplane, they need to rehydrate more because of the compression of the cabin. So again, it's all about keeping blood vessels big and plump. Acute lymphocytic leukemia, immunosuppressed. Remember, any child immunosuppressed, whether it's sickle cell, ALL, cystic fibrosis, even diabetes is immunosuppressed. These are children that you need to prevent them from having infections. They have no immune systems or a limited immune system. So these children would always be placed in a private room because you don't know what the other kid has. Iron deficient anemia. We know that the treatment is diet high in iron, or it's those children using that liquid iron. Remember, empty stomach, orange juice with it's even better. You do it through a straw so your teeth don't get stained. And remember, tell that poor parent that stool might turn tarry, icky, sticky, black colored. I can't imagine having a parent not being told and seeing a child having this big black stool, thinking their child is now dying because of the color of the stool, because that's the way they feel. Orthopedics, juvenile idiopathic arthritis. So, JIA is the body attacking its joints, immunosuppression, right? It says, body, I don't like you joints, and it attacks it and swells it up. Now, there's things we can do to help children and adults with rheumatoid or idiopathic arthritis to feel better. Remember, school-age children loves to be praised, right? So if they're doing what they're supposed to do, which is they are moving and they're exercising, and taking their NSAIDs before they're too bad in pain, these are things that need to be rewarded. Um, Knowing that school-age children are perfect kids to get written instructions because they will follow them. They're very good that way. One of the best exercises for a child with JIA, even adults, is swimming because you are weightless and you're moving your joints and you don't even really feel it. I know me, because I have rheumatoid arthritis, that's where I head to when I'm starting to get stiff. So I've heard many times kids falling off of monkey bars and they fall down and they get on their elbow, they come in and their arm is swollen and they feel miserable. So our first thing that we need to make sure with any broken finger, toe, arm, leg, it doesn't matter, is always to check the neurovascular signs. Capillary refill. Is blood getting distally to that break? Because that, if it's not, it's priority. It needs emergent treatment. But if capillary refill's going good, we could do an x-ray, get a cast on, and we don't have to do anything emergency quick on that child. Now, Harrington rods, what is that used for? This is your scoliosis, right? This is where that S-shaped curvature of the spine, and we get to really see it when children are in that pre-adolescent growth spurt. And we put these metal rods next to the spine on each side. And there's a picture of it there on the bottom on each side. And it's on the ends of the spinal column. So when they are post-op, this is that patient you're going to log roll. Put a pillow between their legs and one roll, turn them over. You don't want to move and manipulate that spine until it's good and it's healed. And osteomyelitis, we mentioned it before. A lot of this is not just the antibiotics to treat it, it's also diet that goes with it. And knowing, is this a kid who's having chronic infections? What's going on? It'd be something that you would ask that child. So have you been sick lately? Why did they get osteomyelitis from a small puncture or whatever it was? And I think this is probably all of yours. The worst scare is cardiac. So let's just break it down a little bit easier for you. Kawasaki is the blood vessels, it's systemic vascularitis or inflammation of the blood vessels. The biggest concern is a carotid artery aneurysm. So, priority procedure to look at is an echocardiogram. You want to look at that, that aneurysm. Is it about to blow, or is it small, or don't they have one yet? That's what the outcomes would be. There's a couple medicines you need to know. Prostaglandins. That's what mommy has that keeps fetal circulation open. And when mommy delivers the baby, prostaglandin hormone goes away. And there are times where we need fetal circulation to continue because This is the oxygen giver of the heart. So, transposition of the great arteries is the one that we would keep it open because we have systemic blood over here and pulmonic here, and there's no connection. So put that PDA. Now we've got oxygen going to the body. It's an oxygen giver until we can do surgery. So prostaglandin keeps PDA open. All right. Now you have a PDA that you don't need and it's open. I see this a lot in premature infants, believe it or not. They're premature, the ones below 30 weeks. A lot of times their PDAs don't close for whatever reason. But what we can do is give a medication, and it's indomethacin. It's actually an IV NSAID. And it's a 3-dose series. And I've told my students, I used to love to give it because I used to listen to the murmur before I started it. After the first dose, I'd listen. After the second dose again, and you watch it decreasing as that murmur is closing until the point it closes. So it's pretty neat as a nurse to be able to see it happen in front of your eyes. I'm a nerd. I liked it. It was fun to watch. So, congenital heart disease. This means the heart was born in a manner, in a way that's not normal. So, blood is going in different directions, being oxygenated in different ways. And we know that surgery can be done, but it's never perfect as a normal heart would be. So you have a child with congenital heart disease. They're getting tachypneic. They're getting tachycardic. They're getting tired out really easy. What you're going to see is heart rate goes up, blood pressure is going to start going down. Listen to their lungs. What is it telling you? The heart's failing, congenital heart disease. The heart's working really hard to try to get the blood and oxygen where it has to go. And it said, I'm really tired here. And it fills up, and you're going to see it in the lungs with listening to it. And also, probably you're going to gain weight, right? Cardiac catheterization. Once we determine there's a cardiac problem, we do a cardiac cath to figure out the extent of it. Remember, they stick two big catheters in the right groin, in the artery, femoral artery, and femoral vein. And the biggest risk is bleeding, not the dye, not the procedure. It's bleeding because of the big size of the catheter in there. And yes, they stop it before they go and bring them back to the room, but it could come off. That clot could dislodge and you could bleed a lot very, very quickly. Remember, digoxin is the same for adults, the same for children. You always look at heart rate, potassium, dig level. You know that you have to know sort of where heart rates are for your younger children. I would look at that before I went into the HESI. We know infants would be 100 to 160, depending on the age of that infant, and as we get older, the heart rate will come down. Just get that in your mind before you go to HESI. Remember, rheumatic fever or acute glomerulonephritis are both caused by strep. And then the big cardiac one that you'll always see a question on is tetralogy of Fallot, where the pulmonary artery all of a sudden clamps off and blood can't go to the lungs. And the treatment is, because you will know they're having it, the O2 saturations go from 100, this happened to me 5 o'clock one morning, to 10 O2 saturations, and it was less than 30 seconds. They went from pink to blue. So knee to chest, whether it's on the side, whether it's on the back, knee to chest, it changes the pressure and usually will open up that lung and get that oxygenation going. So urinary system. Urinary tract infections, one of the signs and symptoms could be new onset bedwetting, just like diabetes insipidus or diabetes mellitus, right? Those would be a couple of things that you would rule out if you saw new onset bedwetting, right? Cryptorchidism is when the testicles are born up out of the testicle sac. And the best way to look at it the best is to put them in a warm room. Men, when it's cold, their testicles suck inwards to protect the testicles. When it's warm, they tend to hang. So you want them hanging as best as you can to get the best visual. Do they have them or not? Are they way up inside? Remember, we talked about osteomyelitis and this antibiotics that we use. That long-term antibiotic is vancomycin. Remember, it's an amnioglucoside, right? Peak and trough levels must be done. And this side effect of this drug is ototoxicity and nephrotoxicity, hearing loss and kidney damage. So you're going to be monitoring that baby's hearing and urinary output when they're getting long-term antibiotics. And nephrotic syndrome. This is when all the protein is urinated out because the body says, I don't like you, protein, and let's get rid of it. So, but what happens intravascularly is all the albumin, which is protein, is also lost. So there's nothing to hold fluid inside the blood vessels. So it pushes interstitially. So you have generalized edema everywhere. You're swollen. Now, one of the treatments we do is to try to replace that protein or albumin. We have 5% and we have 25% albumin. And we give them a bolus of it, and it goes into the blood vessels and it starts to suck out the fluid from interstitially. Then, behind that, about 20 minutes later, we give a dose of a diuretic like furosemide, Lasix, and you will see a gushing urine output, and we know it's working because the swelling is going to be decreasing too. Some more urinary hypospadias, epispadias. This is a question regarding a couple things. Know that this child cannot have a circumcision. We need the foreskin for surgery. And the surgery must be done before potty training. A hypospadias, instead of the urine coming out the tip of the penis, it comes somewhere underneath the penis. So it's not squirting in the right way. So we want to try to get it done and out the tip of the penis before they're potty trained. Also, post-operatively, there is a catheter in there. They create a lumen from the bladder to the tip of the penis, to the urethra, and they fill a lumen. They put that catheter in there to mold it. So that's there for 7 to 14 days. We don't touch it. We don't do nothing with it. We keep it inside a diaper because it will urinate out that tube, okay? That's all we do. Wilms tumor. This is a kidney tumor. Know that this is the one that do not touch abdomen, do not manipulate, very fragile. Not only that, these tumor, we don't do a pre-op biopsy. Why? Well, if we can't manipulate it, why would we put a hole in it to punch it to get a piece of it? Because it's going to lose all of those contents in the peritoneal cavity and create cancer everywhere. So we don't do pre-op biopsy on that. We look at it, we figure out what it is, radiation, chemo, and then we do the surgery. Chronic kidney disease. One of the big problems is osteodystrophy. It has to do with erythropoietin and vitamin D. Know that this is another one that we can be giving erythropoietin, and vitamin D vitamins are foods high in vitamin D. It's another nutrition one here. Acute glomerulonephritis, I said that's strep, just like rheumatic fever. And testicular pain is a true and real emergency. That needs to go to the doctor right away. It could be that the testicle twisted and the blood supply is going away and they could lose that testicle. Respiratory. Remember, croup, if left untreated, can turn into epiglottitis, okay? So, croup. Usually they come into the ER urgent care, and you can hear the barking across the room. Very distinctive. So we usually will give them some sort of steroid, whether they've had IMPO, liquid, whatever, or even sometimes racemic epi aerosols that we do give. The thing with croup and the teaching that you need to tell them is if all of a sudden, after we've given all these medicines, we send you home, if all of a sudden they're not swallowing secretions and their voice is getting really gargled, they need to get back to that ER immediately. That means it's turned into epiglottitis. And once they get back to the ER, diagnosis, possible epiglottitis, make sure that you do have a tracheostomy tray and you do have an intubation tray at the bedside because it's all about airway. Remember children with asthma, children with breathing with the MDI things, making sure that they do have spacers, that they're getting the medicine correctly. That's one of the biggest things that we see with children. They're not getting it, so making sure they have spacer. RSV, remember this is the other medicine, Synagis, palvizumab, as a biologic, and we give that to prevent RSV in those really immunosuppressed, sickly or young infants. First year of life only, from early winter to early spring, and we give it once a month, and it's Synagist. And what we do is we just try to prevent it because children are suck, swallowing, and breathing. They're having a hard time doing that. And then we put mucus in their nose and they breathe through their nose, obligatory nose breathers. So now they can't breathe. So now they're having trouble sucking, swallowing, and breathing. That's why we don't want them to have it. We don't want them to get RSV. Remember respiratory distress in infants. You're going to see all the symptoms as an adult, but add on to that nasal flaring and grunting. That at the end of every breath, that's a scary child. Cystic fibrosis. Why do we give chest physiotherapy? Well, their lungs are like a petri dish full of mucus. We need to thin it up and we need to get rid of it. Remember, we give an aerosol first, that the rescue one, to open everything up, and then we do chest PT. Now it's loosened, now we can get rid of it easier. Know that their skin tastes salty. That means they'll always have a salt shaker. They don't ever take salt away from them. And we diagnose cystic fibrosis with sweat chloride test. Remember, albuterol is just the rescue, right? It's when they're difficulty breathing. That's that rescue that we use. And a respiratory diagnosis that we have seen, I wish we didn't, but some children, our parents don't believe in immunizations. So we do have pertussis around, and I've seen it. Know that the treatment is put them in respiratory isolation now, and the treatment is azithromycin. It is an antibiotic. Remember, with any antibiotic given to children, it could be the first one they've ever gotten. What are side effects common of antibiotics? Nausea, vomiting, diarrhea, abdominal pain, right? So we need to monitor for those because children will get it. It's the first time they've ever gotten this stuff. Their body's not used to it. Okay, gastrointestinal GI. When you have a child with diarrhea, always make sure you check their buttocks for breakdown. Older kids ain't going to tell you they've got a rash down there, and I'm sure that they would appreciate some cream. Younger infants aren't going to sleep at night if we don't see that rash and treat it. Abdominal pain, what's important to ask? Where is it? Is it umbilicus? Is it epigastric? Or is it right lower quadrant pain? Makes a difference. Know that sometimes status post-abdominal surgery, whether it's the Wilms syndrome or whether it's something in their belly, know that if we're going in and manipulating intestines, the intestines doesn't always like that. So the possibility of a paralytic ileus is huge, which means intestines stop working. That means nothing goes down. So what are you going to see? That's that colicky pain, abdominal pain, nausea, vomiting. Nothing's going down, so your belly's blowing up with gas and distension, okay? And it really is because they had to move that stuff, intestines around to be able to do surgery. And that's one of the things that we need to be looking for. Pyloric stenosis, 3 weeks to 3 months, children. This is where they don't just dribble, they projectile across the room. You could point them at a garbage can 10 feet away, and when they're projectile vomiting, they're going to hit the garbage can. That's how forceful and how far that vomit goes. And I'm not exaggerating. It's quite impressive. Um, what do we do for these children? Well, make them NPO. If they're going to have surgery and their ultrasound to diagnose it. Know that this is something that you can feel the pyloric sphincter. Put your hand up underneath that xiphoid process, right upper quadrant, middle quadrant. You're going to feel that olive, or I call it a marble. It's the same thing. It's a hard thing there. You can feel it. Intussusception. This is when the intestines suck into each other really quick and it hurts and it's painful and it's spasming abdominal pains. Okay. Treatment on this is once it gets in there and it's stuck, it swells. So you want to keep them hydrated so that it can come out by itself without doing manipulation or surgery. Okay. So intussusception, the way that we can confirm that cramping, colicking, abdominal pain is look at their diaper, look at their underwear. You're going to see a little bit of current looking material, maybe some blood streaks in it. That'll be your diagnosis, current jelly. Gastroesophageal reflux disease, older children. We know that's the cough and that's the, complaining of chest pain. And we can say, oh, that's mini aspirations. That's probably reflux, right? So, what diets do we eat? Well, no chocolate, no sodas, no spice. A plain cookies, probably of everything. Yes, it's sugar, but if I was given things with sugar, with spice and chocolate and grease, this would be my best choice. So, picking it, you'd have to think about what doesn't have that spice and that grease in it. If you have a child who looks jaundiced, and their sclera is yellow and their urine gets tea colored. Their stools are very white, they're pale looking. This is biliary atresia. I've seen only one in my career, and he did. He turned yellow, his eyes turned yellow, and his urine was very, very dark. That's one of the things that clued us into it was, the turning of the yellow, and then of course, we watched his enzymes, etc. Gluten diet, I've mentioned it already. It's watching out for wheat, rye, and barley. We cannot eat a lot of fat. The body does not absorb it, even with giving those extra enzymes. So, high carbohydrate, high protein, low fat diet. Neurological, you're a school nurse. You have a child come in saying, I have some ringing in my ears. What would you do first to look at that? Well, look inside, do an otoscopic examination, right? I've actually seen beetles, and I've actually seen a bee, and I've seen an ant inside an ear. And the beetle was alive. That one creeped me out because I could see the little feet. So what we did is we put oil in there actually, and we floated it out and we pulled it out, and the oil smothered that. But anyway, ringing in the ears, look first. Meningitis. Remember, we get all the symptoms of the meningitis, the nuchal rigidity, photosensitivity, fever, headache, all that. Well, is it viral or is it bacterial? It makes a difference on how we're going to treat it, right? So always remember, to diagnose meningitis, you need a lumbar puncture. And that's going to tell us viral or bacteria. Remember with seizures, It's all about safety, making sure their area is safe, their airway is open, turning them on their side, calling for help if we need it. Very much so. Safety. Not let them swim out in the middle of a lake by themselves if they have seizure disorders, because they could have a seizure in the middle of a lake. Those are other sort of safety things. Febrile seizures. My firstborn grandson had a seizure at 18 months. And this was the first question my daughter-in-law asked me. Does this mean my child has epilepsy? And I said, no, it just meant that he had a febrile seizure. And you know something? He never had another one. And he's now 13, so he's grown out of it. But it's very scary. Febrile seizures we usually grow out of somewhere about age 6, and we could tell parents that. Seizures, epilepsy, are one or more unprovoked seizures a day. Myelomeningocele is that picture up there. It's that big blob open on the back. That's their meninges and spinal cord's been pulled up and out and ripped up, and it's underneath that blob. Know that our big thing is normal saline, sterile dressing, keep the skin integrity. And now we've got a child who's going to have decreased sensation in the lower extremities. Not only decreased sensation, you have to worry about urine. Sometimes they need catheterizations, and their bowels. Sometimes they need help moving their bowels every day or every other day. And this child, we've always, from the get-go, that we make them latex allergy because of the amount of touching with latex that will happen in between just the manipulation and urinary catheterizations. ADHD in children, the big thing is keep them on routines, quiet space, place to do their homework, those things that you need for them. It doesn't mean that they need meds. It doesn't mean that non-stimulant meds don't work. No, we just need to have that routine, constant place to do homework so they know where and what they're supposed to do when they're in a certain place, because these kids are all over the place. Some more Duchenne muscular dystrophy, more neuro. Remember, Duchenne muscular dystrophy is a progressive muscle degeneration in boys. Ages 3 to 7 is when we diagnose. And it's now that they are up, they were walking, they've got hypertrophic calf muscles, and now all of a sudden they're falling down. And they're falling down more and more as they get older. So the test we do to diagnose Duchenne is called an EMG, an myogram. What it does, it takes either through a little tab or a tiny needle, it puts a little electrical shock into a nerve, and the machine measures how quick and how much of a response the muscle had to that shock. Now, when these children come back, they felt like they ran a whole marathon. So make sure that we give them some ibuprofen or acetaminophen or something. Remember eyes. If they have something stuck in them, we never take it out. Put a Fox shield, which is a hard shield, on both eyes and get them either to a pediatric ophthalmologist or pediatric emergency room to take care of it. Nystagmus is that literally that cross-eyed going on, that little movement, right? Hydrocephalus. We've mentioned it before, knowing that if we're seeing increased head circumference, now that we're looking also at fontanelle, a ventricular peritoneal shunt. A lot of our myelomeningocele will end up with a ventricular peritoneal shunt. And of course, that's done at birth. And kids grow, and sometimes they disconnect. And you would see a kid come in, headache, vomiting, always. So these children come in, we do the x-ray, we find that shunt's not working right, send them to the OR. How do we know that shunt is now working? It's as simple as the headache's gone and no more vomiting. Now we have taken care of that pressure in the brain. Endocrine. One of the big things, and I try to make this point when you were doing your projects, is that endocrine will always measure height and weight. There's not no problem, there's no issues. You're measuring height and weight. So that's always going to be an endocrine issue. Normal height and weight for age. That's exactly it. Remember, the parathyroid has to do with calcium. It has to do with muscles. So any problem with weak muscles will always be a calcium problem. Remember, calcium, magnesium always work muscles. Parathyroid is specific calcium. Remember, with diabetic ketoacidosis, our initial treatment is given a fluid bolus and starting that regular insulin, IV, continuous slow infusion. And we're just going to be adjusting the rate according to the blood sugars on them. Kids that are diabetic want to be normal, just like any other kid. Making sure they have a little snack, checking their blood sugars before they go out and play is all they need to do. We need to teach children how to rotate the injections, because if they're a 2-year-old just becoming diabetes, by the time they're 80 years old, can you imagine how many injections they've had? So if we don't rotate them, they're going to have crunchy areas, because too many injections in one place, it gets like crunchy, believe it or not. So make sure we rotate them. Teaching them the signs of hypoglycemia. If they are awake and alert, sweating, shaking, complaining of headache and nausea, treatment could be milk, could be orange juice, something with sugar. Another thing with endocrine, and it's a trick question, remember, if the TSH is high, the T4 is low. And if the T4 is high, the TSH is low. Remember, those two are opposite of each other. It's just one of those weird questions about feeding infants. And we just know that. That's just normal body function. And in an adolescent, BMI is really high, means they're really overweight. What do you think overweight in an adolescent could be? Well, it could be, well, what symptoms are they having? Could they be diabetic, increased urination? So checking hemoglobin A1C, checking urinary tract infections, all of those things are important because it could be diabetes. Some common kid diseases. We don't really go over these in class, so I've hit you with a couple that you should know. Impetigo is a staph infection. My Christian had this on the back of his leg, and I watched it spread, and it was painful, oozy, juicy. And what we do is we apply that antibiotic ointment to the topically, and oral antibiotics also are given. What they say is do not pop those vesicles. That juice, that liquid inside these sores, it will spread and it will get more and more. So don't pop them. Conjunctivitis, very common in kids, right? Remember, if we're cleaning them, warm, wet rags, don't ever cross contaminate, right? One washcloth for this side and one for this side. Wash them inside out, get rid of all of the junk. And if we have to use an ointment, please let them know they're going to get blurry, because kids will really get upset if I can't see, it's all blurry. Oh my goodness, I can't see now. You don't want that. Ticks. Ticks will always have a question here somewhere. So you have a kid that's had a tick removed and now they have a fever. What are you going to do? Well, this is where you need to go get them to the doctor to be tested to see if they have Lyme disease. That's our biggest concern with ticks. Remember tetanus. That's where that jaw starts and lockjaw, and this is something that can occlude the airway. This is with stepping on that rusty nail. Remember to clean the puncture place, whether it's a finger, a toe, a foot, a hand, making sure that we clean it with soap and water. An antibacterial antibiotic ointment is all we need. And of course, checking the immunization status. Chicken pox. They are where you can get the disease 2 days prior to the onset of the rash, and they're infectious until all of those lesions are crusted. So a child could go back to school after all the lesions are crusted. Head lice, remember to inspect the hair follicles. There's medicine we use, and that fine tooth comb to get out all of the little lice that are in there. Otitis media, remember, breastfeeding that first year of life decreases the incidence of otitis media. That's one of the things. Also, no smoking around children. Increased smoke in their presence can cause increased ear infections. And ADHD, again, stimulant meds can be used. No, there's organizational charts, consistent schedules, and again, as I said, one area for their homework. I've already mentioned the nosebleed, thumb, and the finger. And let's look at infectious diseases. One of the things that was mentioned is low neutrophil counts. Now, we mentioned them in regard to going under chemo and NADAR period and all of that. But remember, any child, adult can have a low neutrophil count, usually overwhelming sepsis. It could be an immunosuppressed person, but it doesn't have to be. Whenever we see a low neutrophil count, this is your priority patient, especially if they have a fever already, because there's no immune system. This child, this adult's going to go into septic shock very quick. So that would be your priority. Remember, infection control is all about washing hands. That's always number one. And also teaching parents, like if they're in respiratory isolation, to stay in the room, that the kid can't come out unless they have a mask on and if they're with one of the nursing staff. An immunosuppressed child, the priority treatment that we know, and I've already mentioned it with low neutrophil count, they have a fever, they're immunosuppressed, this is always your priority patient. When we give immunizations to children, remember those first 2 months, 4 months, 6 months, we give what, 4 different immunizations each time, and they hurt. Know that we can bicycle those legs. It's called pedaling the legs. It helps mush in all of that immunization, all the liquid into the thighs. It helps. Also, a cool pack. And then if they are above 6 months, they can have ibuprofen, but younger than 6 months, only the acetaminophen can be given. The MMR, the measles, mumps, rubella, is given at 12 months, the second at 4 to 6. We know rheumatic fever is by strep, and everything will go away except that mitral valve. And then bone marrow aspiration. As I said, this is a crunch, and it does hurt, knowing that post-procedure medicate for pain, maybe even a cool pack. Now, this is the last slide. There was one HESI that had 4 different acid-based questions. So let me go over 3 of them, and you won't forget them. So when we have diarrhea, we are losing all of the alkaline enzymes that digest food. So you're getting rid of alkaline. So diarrhea, what's left? Metabolic acidosis. Now, if we are vomiting, what are we vomiting? Stomach acid. So if you're vomiting acid, what is left? It's alkaline. So metabolic alkalosis is for vomiting. Now, if we are in Kussmaul's respirations because of DKA, well, if you're in DKA, you're in metabolic acidosis. So the body tries to compensate all the time. So it starts that hyperventilating, and that is respiratory alkalosis. And I think that will help. When you're doing this essay, please remember, when you think you have the answer, go back, read the question to make sure you're answering the correct question. And that's really the most common thing that I see. I wish you all good luck. Thank you all for showing up. and I'll be posting this as soon as I can. It will first go to my YouTube channel. So it's Professor Bogart, Pediatric Nursing. That's the first place it will go. So if you want it quick, there it is. If not, I'll be sending it to all the professors and it will be posted online. Thanks, guys.
Thank
Thank you.
Good
you.
luck.
Thank
Good
you
luck.
so
Good luck.
much.
Good luck.
Thank you.
My pleasure.